Hello everyone, welcome to Dr. Sam's anatomy classes. Myself, Dr. Azmi Mohsin. I'll be teaching you about the clinical and applied anatomy of the facial nerve. Before this, I have already taught you about facial nerve in detail, so I hope you remember that. We'll continue now with the clinical and applied aspects of facial nerve. So, this functional column, remember, special visceral efferent, the motor fibers to the muscles derived from the second branchial arch, that includes the muscles of the facial expression. We are going to focus here on that. And like any motor descending tracts, it also has supranuclear pathway and infranuclear pathway, the upper motor neurons and the lower motor neurons. Okay, so we will talk about supranuclear lesion of facial nerve. So what happens if there is any lesion in the supranuclear pathway of the facial nerve? What's going to happen? Let's check. The important thing here, I told you before, remember, while I was teaching you about the motor nucleus of the facial nerve, remember that the muscles to the lower part of the face, they have only the contralateral representation from the cerebral cortex. The upper motor neurons supply only contralaterally to the opposite lower half of the face, while the upper part of the face is supplied from both the sides, ipsilateral supranuclear neurons as well as contralateral supranuclear neurons. They innervate the upper part of the face. So the upper part of the face has a bilateral representation. Now look here, this is the cerebral cortex we are talking here. This cerebral cortex is actually the precentral gyrus, that's the primary motor area number 4, from where these, and that has a somatotropic representation, that's upside down representation of the body parts, especially the face here is every features there, the portion of the body which has more of innervation, that has a bigger area demonstrated here, represented here in the precentral gyrus, that is the primary motor area. So the fibers, the supranuclear fibers, they descend down, and of course they will pass through the internal capsule as well, and ultimately they'll reach down at the lower level of the pons, where you find is the facial nerve nucleus. Now upper motor neurons from one side of the cerebral hemisphere, just like the normal the corticospinal tract, we told you that majority of the fibers they decussate. 85% fibers they decussate, remember, the corticonuclear spinal tract, while 10 to 15% fibers they descend down ipsilaterally. That's going to happen here also, that the cerebral hemisphere of that one side, they have these fibers descending down to the same nucleus on both the sides. These are the 10 to 15% fibers, while 85% fibers nearly they decussate here and they reach to the opposite nucleus, right? So this is what I'm talking is fibers coming from the upper part of the face represented in the motor homunculus, right? So that's how the face is represented. So that's way, even while we were talking about the nuclei present in the anterior horn of the spinal cord, remember, there was also a somatotropic representation in the ascending tracts and in the descending tracts, remember, in the cervical and lumbar swellings. The lateral group of nucleus in the anterior horn of the spinal cord, they were divided into the subnucleus. You have an anterior, then middle, and the posterior, and posterior most lateral group nucleus, which was supplying, the most anterior was supplying the pelvic or the arm region, axillary region, brachium region, thigh region, and the middle portion was supplying the leg, the hand, the forearms, right, and the posterior most was supplying fibers to the hand and the foot in the cervical and lumbar swelling respectively. Similarly, what I want to tell you is that the representation of the face, parts of the face, is not only, that's called somatotropic representation, that's not only represented here in the area 4 of the cerebral cortex, but it's same way it's represented here also in the facial nucleus. So the fibers coming from the area representing the upper portion of the face, they decussate and reach to the opposite nucleus as well as on the same side. Then the portion of the face which represents the lower portion of the face, for fibers from that portion of the cerebral cortex will completely decussate, right? They will completely decussate and reach to the opposite nucleus. So that's the peculiarity of this facial nerve nucleus. That's not happening like for the entire face. The lower half of the face is represented only contralaterally, while the upper portion of the face has the normal representation, right? That is called 80% decussation and 10%, 15% ipsilateral. So upper part of the face has the normal way of representation that's happening with rest of the body parts as well. Only the lower portion has this peculiar thing, that it has only the contralateral representation. The 5 upper motor neurons completely decussate to reach the opposite nucleus. Now look about the lower motor neurons. The lower motor neurons, they of course, this facial nerve nucleus is same as any anterior horn nucleus of the spinal cord. So the fibers emerge, they will form a bundle, and that's called a nerve, and that's facial nerve. So all the fibers for upper as well as lower part of the face, they will innervate that particular half of the face. But because the upper part of fibers to the upper part of the face, they have stimulus being received from both the sides, ipsilateral and contralateral. So that why upper part of the face has bilateral innervation from the cerebral cortex, while the lower portion of the fibers from that portion of the nucleus which is receiving only from the opposite side, from there the lower motor neurons will emerge and will innervate the lower portion of the face. So that's why what you conclude here is that upper part of the face is receiving fibers from the cerebral cortex from both the sides, while lower portion of the face is receiving fibers only from the ipsilateral side. So now you look here is like we discussed here, we discussing here is supranuclear lesion of the facial nerve. This is we are discussing is if there is any lesion here, right, in the supranuclear pathway. So if you say is this the left side, which is left sided lesion in the supranuclear pathway, so what is going to happen here, that the ipsilateral side will have a complete normal side, because the fibers both to the upper part and lower part of the face, they are coming from the opposite side, right? Although there might be some damage to the ipsilateral fibers, that hardly matters because most of the fight was coming from the opposite side. Got it? So the same side of the face stays normal. Now what you see in the opposite half of the face, while in the opposite of the half of the face, in the upper quadrant, in the opposite half of the face, that also will be spared because there are fibers for ipsilateral fibers reaching to the same nucleus. So there will be not much motor loss, while in the lower quadrant of the face of the opposite side will be completely paralyzed, because that was the region which was receiving only contralateral fibers. So ultimately, if there is supranuclear lesion, or let's say on the left side, the resultant will be that there will be contralateral paralysis of the lower half of the face. So if there is left sided supranuclear lesion, there will be right sided paralysis in the lower half of the lower quadrant of the face on the opposite side. So what is going to happen now? Look here, like how the patient will be presenting. So in this case, he can easily close both the eyes, because Orbicularis Oculi closes the eyes, and that's functioning normal. There will be transverse creases on the forehead because frontalis is again innervated by both the sides. Now in the lower portion, what happens here, the constrictor of the oral orifice is Orbicularis Oculi. Now this is going to be damaged because of the opposite side quadrant is paralyzed. So when the patient presents, his lips or the face will be slightly pulled to the same side of the injury because of the normal side, right? And there will be actually in presentation, when person presents himself in front of the doctor, he will hardly have much facial differences if he or she stays calm, right? And if an elderly is there, might you find that the creases of the skin might be a little smoother on the affected side. But this will have to be checked out. And one thing is like the presenting complaint, when the signs which you observe on the face. Now when you test him or her, you ask the subject to blow air in the mouth while closing or pursing this oral orifice. So when she or he will blow air and try to whistle, you will find that his oral orifice, the oral fissure, has been pulled towards the normal side, and the air is leaking out from in the corner of the oral orifice on the affected side. And now you'll find that the nasolabial fold is more prominent on the normal side, and it is faded out, and the skin becomes more smooth on the affected side. And why he will also complain about, like, while eating food, the food collects in the labiogingival sulcus because of the paralysis of buccinator. So this all features you are going to find in the opposite, or you can say on the contralateral lower quadrant of the face in case of supranuclear lesion of facial nerve. I believe you've understood. Now before moving to the infranuclear lesion of facial nerve, just have a look here. Infranuclear means we're talking about facial nerve, and facial nerve is made up of lower motor neurons arising from the nucleus and will supply on the same ipsilateral side of the face, half of the face. Got it? So if it is damaged here, right, if it is damaged here, the facial nerve, all the fibers, maybe upper quadrant or maybe the lower quadrant of the same side, will be injured, and that will lead to ipsilateral paralysis of the same side of the face. Got it? So now we will move to the next slide, and we will talk about infranuclear lesion of facial nerve. Here you seeing is the nucleus of facial nerve, and all the fibers, whatever might be represent, we will be talking about the infranuclear lesion. So it hardly matters fibers coming from same side or opposite side in the supranuclear pathway. Ultimately the fibers, they're reaching from the lower motor neurons of the facial nerve to the same side, same half of the face. Got it? So such subject will, when present to you in front of you, you will find smoother surface of the face on the affected side, while you'll find there are creases like nasolabial fold on the face. On the normal side, there will be transverse crease in the forehead because of frontalis and all. The lips might be pulled towards the normal side. Got it? So these are the presenting signs. Then in such patient, when you check or will test for this lesion, you again ask the subject to blow air in the mouth and try to purse the mouth. Then what you'll find here is the entire half, because you're trying to check for the muscles of the face, innervation of the muscles of the face. You will find that the half of the face is smooth on the injured, affected side. The normal side will have the normal creases of the face, plus the air is leaking out from the corner of the oral orifice on the affected side. Chin, the folds, the creases on the chin, that also will be present there. Then one more thing, have you noticed that she will not be able to completely close the eyes on the affected side. Now here it's Orbicularis Oculi that also is damaged. This feature will not be seen in supranuclear paralysis, because remember that the Orbicularis Oculi comes into the upper quadrant of the face. So this feature will help you distinguish rather between the upper and lower motor neuron paralysis while asking him to close the eyes. So on the affected eye, he or she will not be able to completely close the eyes. Remember, elevation of eyelids is different thing. That's by a sympathetic control as well as oculomotor nerve. So we are not to think about opening of the mouth. Here we will ask to close the eyelids. So he or she will not be able to completely close the eyes. And rest of the history, of course, that he or she will tell you that while eating food, while chewing, the food collects into the labiogingival sulcus and all. And these are the features you will find in the. And this person, like habitual and social life, she will have this that she will not smile regularly, because she knows that smiling makes his face disturbed, features gets disturbed here. Anyway, so you got to know now. Think about why is it happening, what were the causes of the lesion, what make and what are the things which are spared while this injury happens. So this diagram, this slide, you are seeing the two faces. The first one is the subject sitting in front of you with the infranuclear facial nerve palsy, right? This is how he will present in front of you, and while presenting you will find the affected palpebral fissure is more widely open than the normal side. One thing. Other thing is the nasolabial fold is a little faint or diminished on the affected side, will be more prominent on the normal side. Here we are talking, remember, I believe you understood that we are talking is on this half of the face, the right side of the face. Okay, so in this side you find that the nasolabial fold is also a little diminished while it's more prominent on the normal side. The lips are a little pulled towards the normal side, and this is how and there might be creases, clearing of the creases on the neck on the affected side. Then you ask to check this subject for your diagnosis if it's supra or infranuclear paralysis. Now what you'll check here, ask the subject to close both his eyes. Then you will realize, can you see the difference here? In this it was wider open eye, the presenting complaint, and the normal eye was the palpebral fissure was less of open. Now while checking, when you ask him to close both the eyes, you will find he is not able to completely close the eyes on the affected side, and this is what is differentiating it from the supranuclear lesion. Then the same thing is like while blowing air, you will find first of all the lips will be more pulled towards the normal side. The nasolabial fold will completely vanish because now blowing of air is there and this muscles will pull it on the opposite side. So the in presenting complaint there was a slight nasolabial fold, but on being checked that faint fold also is vanished. And then rest of it is like slurring of speech also, because there is air leaking out, and creases on the neck also are less of folds you'll find on the affected side in the neck also. This is how you've got to know about the features and the clinical testing of Bell's palsy. Remember, Bell's palsy is infranuclear facial nerve paralysis. because of infranuclear lesion of the facial nerve. Now, what is going to stay normal? Because facial nerve right from the lower portion of the pons, right? Initially, it was having an intraneural course within the pons, then it was having an intracranial course within the subarachnoid space reaching to the internal acoustic meters, then it was having an intrapetrous course which was within the petrous bone, and in the petrous bone it was having giving out three branches: greater petrussial nerve, nerve to stapedius, and chora tympani, right? So, and then after that it emerges out through stylomastoid foramen to give branches: posterior-auricular, then branch to posterior digastric, stylohide, and then the 5 terminal branch to supply the muscle of the face and scalp. Now, actually, majority of the cases, this facial nerve Bell's palsy we talk about is happening here outside the cranium, right? And outside the cranium, this point of exit of facial nerve from the skull is stylomastoid foramen. So normally this injury happens here at the stylomastoid foramen, and it might be an ischemic injury because there's an artery, because that entire intrapetrous course of the facial nerve, this is covered by bone. It is running in the facial canal as well as in the internal acoustic meters. Then the portion which was in the internal acoustic meters, there was blood vessel called labyrinthine vessels, which was supplying blood to the bony apparatus, the internal ear, the vestibulocochlear nerve, nervus intermedius, facial nerve. And while here from the exit side in the facial canal, it is this branch of posterior auricular artery, the stylomastoid branch of the posterior auricular artery, which is also sometimes given off from the occipital artery. So, in chills and blains in very cold weather, sometimes because of this chills also there might be some injury or might be some compression at the side which might cause to damage to this facial nerve at the stylomastoid foramen. So, okay. So, what is going to be spared here? Remember, because the three branches given out in the petrous portion, they are spared. So what will going to happen in Bell's palsy, that the taste sensation will remain intact. Why? Because chorda tympani is normally functioning, that hasn't been damaged because the damage is outside the skull. And mucous secretions around the mouth, pharynx, nose, and paranasal sinuses, they will be intact, because remember, the greater petrussial nerve is the first branch of the facial nerve, that also is absolutely normal through the pterygopalatine ganglion. All secretions are going well. Then lacrimation is, of course, lacrimation will not be damaged, it will be normally functioning, because the greater petrussial nerve through the pterygopalatine, through the zygomatic, through the zygomatico-temporal, through the lacrimal nerve, it is the entire course is normal. So lacrimation will be normal. Hearing will be intact. Remember, there will be no hypoacusis because remember, let me tell you, there will be no hyperacusis because normally the function of Stapedius muscle is to dampen the oscillations of the stapes over the oval window. So the high pitched sounds reaching to the internal ear are dampened by Stapedius. And if Stapedius is paralyzed, what is going to happen is that the normal sounds will be high pitched. You will hear even the whispering will be high pitched for you. I mean, such a subject will be, this condition is called hyperacusis, right? The dampened sound will be even heard loud. So that's called hyperacusis. But this is not going to happen here in Bell's palsy, because nerve to stapedius is again a branch within the petrous bone. So all these features you are seeing here, all these features, they will be normal, they will be intact. Because Bell's palsy is normally, when we talk, Bell's palsy is the lesion of facial nerve outside the stylomastoid foramen. So what the causes are. So the causes is considered, actually it's actually idiopathic. Let me tell you, most of the people complain like while they were normal until yesterday, then they slept the night and they wake up in the morning, they got this problem of facial disfigurement suddenly happened. So this the cause is mainly idiopathic, and sometimes below the stylomastoid foramen, that is ischemic cause of stylomastoid branch of posterior auricular artery might be damaged, or because of chills and blains, the cold weather also sometimes damages this nerve. Remember, normally you've seen in very cold weathers, you people wear caps, and it's always advised to protect your pinna from the cold. So people cover their ears, the pinna, while going out in the cold. So again, it's advisable to protect your ears, because the chills that might damage the facial nerve emerging behind this auricle, between from where does it emerges? It emerges between the external auditory meatus and mastoid process, right? And between the styloid process down this, between the styloid and mastoid process. So that area has to be protected in cold weather to prevent this Bell's palsy. That was about infranuclear lesion of facial nerve. Now this diagram is very important for your MCQ purpose in your PG entrance exams, as well as now for 2019 batch MBBS. There will be MCQs also. It's supposed that there will be MCQs now in the university exams. So make sure you know all this diagram very well. What are the losses which you're going to face at different points of injuries? This is the facial nerve course. I believe you can stand here. This is the internal acoustic meatus. So this is the intracranial portion. Then in the intracranial, in the petrous portion, this within the internal acoustic meatus, nervus intermedius joins the facial nerve, and this is the first bend here at the fundus of the internal acoustic meatus, where this is called genu, and there the facial nerve also has its sensory ganglion called the geniculate ganglion, and from that geniculate ganglion, there's this first branch of the facial nerve that emerges out, is called greater Petrussial nerve. Then this first bend is actually antero-superior to the promontory. Then this portion here is the second portion of the facial nerve, which runs above to the promontory of the middle ear in relation to the medial wall of the middle ear. Then this is the portion, the second bend, which runs posterior superior to the promontory. Then this gradually descends down, and this actually has nearly a vertical course. So this much portion here is running the facial canal, and you can see it is emerging out at the stylomastoid foramen. So these two branches are given out from the third portion of the facial nerve in the petrous temporal, and this is the nerve to Stapedius. I told you it, Stapedius muscle, remember, it also develops from the second brachial arch. So it innervates Stapedius. Stapedius, remember, Stapedius dampens the vibrations reaching the middle internal ear. So it actually decreases the high pitched sounds from reaching the internal ear, and if it's damaged, normal sounds will be heard loud, and that's called hyperacusis. And before that, let me tell you, now there is another muscle in the middle ear cavity that is called tensor tympani. Remember, that muscle is developed from the first brachial arch, right, innervated by mandibular branch of trigeminal. Okay, so these are two muscles, tensor tympani and Stapedius. Both muscles are within the middle ear cavity, but they are acting differently, opposite. Tensor tympani is attached to the handle of the malleus, and malleus is attached to the inner surface of the tympanic membrane. So tensor tympani, as the name suggests, it tenses, it tenses the tympanic membrane, making it to vibrate more, to increase the pitch of the sound, right? So so that the normal sounds can be, normal or whispering sounds can be heard clearly. So it increases this tensor tympani muscle, increases the normal sound to high pitch sounds, right? So in cases of paralysis of injury to tensor tympani, there will be hypoacusis. Remember this, hypoacusis because of damage to tensor tympani. Then hyperacusis will be a problem when there is injury to stapedius. Stapedius decreases the high pitch sound, and if it's damaged, the normal sounds will be heard loud. So this is nerve to stapedius. And then within the middle ear cavity, this branch of facial nerve, the third branch, is chora tympani, which traverses through the middle ear cavity, and it emerges, it crosses between the, epitympanic recess between malleus and incus, and emerges out to the petrotympanic recess out of the facial skull down in the infratemporal fossa, where it joins the lingual nerve and reaches to the supply the anterior tooth of the tongue. By the way, before, and the further the course is, like, it emerges out the Tylomastoid Foramen, and it gives branches to posterior auricular branch to digastric posterior belly, then stylohyoid, and the further 5 terminal branches passing to the parotid gland to supply the muscle of the face. This is all you have understood. By the way, and before that, let me tell you that this geniculate ganglion also receives, sympathetic fibers from the plexus around middle meningeal artery, and this nerve is called external Petrussial nerve. Remember, the geniculate ganglion has connections with the sympathetic plexus around middle meningeal artery, and that's called external Petrussial nerve. Okay, and don't forget, I told you while I was teaching the facial nerve, there is another communication from geniculate ganglion to the lesser Petrussial nerve as well. Will not go into that. Communications are a lot of complexities which disturbs you from the basic things which I have to teach. So if think about greater Petrussial nerve, what it is doing, it's providing secretomotor fibers to the mucosal glands in the middle of the face around the nose. Remember, that's a maxillary area, including the lacrimal secretions. One thing, greater Petrussial nerve, what else it does, it brings the general sensations from this area, from the middle portion of the face around the nose and oral cavity and pharynx and paranasal sinuses and orbits, right? So general sensations are being carried, and special sensations also, taste sensations from the palate, are being brought in through this deep Petrussial nerve. It's clear now. Stapedius is only, special visceral efferent, so only the it's related with the contraction of stapedius. Then about chora tympani, what was this doing? Chora tympani is carrying again, special visceral afferent and general visceral afferent. Special visceral afferent, or of course general visceral efferent also. Now chora tympani is carrying parasympathetic secretomotor fibers to the submandibular sublingual salivary glands as well as anterior and posterior lingual glands. Chora tympani damage means loss of salivation. Then it's bringing in special visceral afferent sensations from the, that's a taste sensation from the anterior to the tongue, as except the circumvallate papillae. So that taste sensation will be lost if chora tympani is damaged, as well as the general sensations from these, general visceral afferent, the sensations from the gland that it innervates, those fibers will also be damaged. So you have to have idea about what is going to, any injury which is proximal to that branch will cause loss to that structures innervated. So let's see if it's damaged here, right? And these are the loss of sensations mentioned here. You can see these, they have mentioned is the losses suffered in cases of injury at particular points. This is the same diagram I taught you about Bell's palsy. It's the ipsilateral paralysis of the half of the face, right? Now look here, first of all we'll talk about this point here, injury over here. So if there is injury at this point, that's outside the stylomastoid foramen, and that is of course Bell's palsy, you know that. So what is going to happen, you will have paralysis of muscles of facial paralysis of the muscles of facial expression. That was taught to you. Now think of, because they'll ask sometimes, if there is an injury happens here in the middle ear cavity, in the medial wall, in the facial canal, somewhere above the chorda tympani, what will happen? There will be hearing sensations will be normal, tearing will be normal, right? What is going to be damaged is 3, 4 and 5. Look here, loss of taste from the anterior two-third of the tongue will be gone, but sensation from circumvallate papillae will be normal because they are being carried through glossopharyngeal, you know that. Then loss of salivation also will be lost, and of course the paralysis of the ipsilateral half of the muscles of the face. Got it? If there is an injury here above to nerve to Stapedius, what's going to happen now? Apart from all those whatever we have discussed, there is an addition of point number 2, and that is loss of stapedial reflex. That means there will be hyperacusis, right? Even whispering or low pitch sound will be heard loud. Okay? So hearing will be impaired. Then if there is injury in the internal acoustic meatus, right here before the Caesarean ganglion, before this geniculate ganglion, so all the features we have already discussed, there will be in addition to point number 1, and that you find is loss of lacrimation also will be damaged. And more precisely, if there is an injury here in the in the trunk of the facial nerve before proximal to this spiral ganglion, apart from all the losses we have already discussed, there will be loss of lacrimation, plus there will be loss of taste sensations from the palate, because they might like differentially ask, separately ask, because tongue sensations are being, taste sensations from the tongue is brought in the chorda tympani, and from the palate, from the actually there's a communication here between chorda tympani and greater Petrussial for fibers for the taste, actually from the palate also join from greater Petrussial to the chorda tympani. So ultimately there will be loss of sensations from the palate also, and there will be loss of secretions from the nose, from the palate, from the pharynx. This is all everything about facial nerve, and all the lesions at different sites have been discussed. So you should be prepared to answer MCQs regarding injuries of facial nerve. I have taught you in detail. Next is about clinical anatomy of facial nerve, some other injuries. Facial nerve palsy in a newborn. Facial nerve palsy in a newborn. Let me tell you that this mastoid process behind the bony prominence behind the pinna is actually late to develop, not in a newborn. It develops around after 1 year, you can say around completion of the 2 years of life. After 1 year it starts developing and it completes you can start palpating this mastoid process after 2 years of life. So if in a newborn there is no mastoid process, so what happens is that stylomastoid foramen, remember stylomastoid, the name means it's between the styloid process of temporal and the mastoid process. Styloid process is medially placed and mastoid is laterally placed. In between is the foramen from which facial nerve is emerging, and if there is no mastoid process, what will happen? The stylomastoid foramen will be on surface, right? And you can palpate, you can press upon stylomastoid foramen instead of when you will try to palpate the mastoid process in newborn, you are actually putting your finger on the stylomastoid foramen. So you can imagine of an obstructed labor. or a difficult labor, obstructed delivery, there are chances of mishandling of the fetus while this act of parturition. There are chances while handling the head of the fetus or a newborn, you might press upon this facial nerve behind the ear, because there's no mastoid process and the stylomastoid foramen is on surface. So that can lead to a congenital defect. Since birth you will find that there is facial nerve palsy in a newborn. But tell me now, you, as I told you, there are presenting complaints for a person with facial palsy. Then there are clinical tests. You ask them, to blow air, you close the eyelids. But what about newborn? How are you going to test it? So the best thing is, remember, buccinator is the muscle which approximates your cheeks towards your teeth. It actually closes or approximates your cheeks towards your teeth, causing a negative pressure inside. That's why whistling is what are the muscles utilized in whistling? Whistling, you actually, when you blow air, you first of all purse your mouth with Orbicularis oris, so that your air doesn't leaks out. The one muscle involved in whistling, generally people or the students, they say, if you ask them like which muscle is the muscle of whistling, they'll say buccinator. But remember, buccinator alone is not a whistling muscle. Buccinator can do nothing if the oral cavity is not, if the oral orifice is not closed. So with the help of Orbicularis oris, you purse your mouth, and then you contract the buccinator. So buccinator, it compresses, it approximates your cheeks towards your teeth, creating a positive pressure inside, and that leads to leaking of air from the oral orifice, causing whistling. Here, what of the purpose is, remember, everybody who must have studied that in a newborn or an infant, there is enough amount of buccal pad of fat, and that is for suckling of milk. So because of that pad of fat in the cheeks, there is negative pressure created along with buccinator to suck the milk. So in a newborn with this sort of problem of facial nerve being damaged, the parents, the mother will complain that the baby is not able to suck the milk. I hope you've understood this. Okay, then we will talk about let me change to new color. Yes, now we will talk about crocodile tears syndrome. Crocodile tears syndrome is very much similar to Fraze syndrome. First of all, remember that Fraze syndrome में क्या था, पेराडोक्टोमी ऑपरेशन करा रहे थे, रिमूवल ऑफ parotid gland, because of iatrogenic reasons, or maybe because of regeneration of neurons post-op regeneration, because there are two different nerves reaching to this region here, to the secretomotor fibers to the parotid gland were reaching through auriculotemporal nerve, while the skin overlying to this parotid region and the angle of mandible was by greater auricular nerve, right? So after this surgery, there is normally axons regenerate within the within the neurolemmal sheaths. So because of the regeneration, the fibers of two nerve they fuse. So what happens in Fraze syndrome, that while eating salivation to ho gayi, right? There will be salivation not from the parotid, of course, but while eating, what happens, there will be redness and sweating in the angle of the mouth in the parotid region. That was about Fraze syndrome. Now remember, crocodile tears syndrome is same thing. Crocodile tears mein what will happen here, you just focus on this first branch of facial nerve. or rather the geniculate ganglion. The geniculate ganglion was the ganglion from which this branch greater petrosial nerve was arising, and this nerve was carrying secretomotor fibers for the lacrimal gland as well as for the mucosal glands in and around the nose and oral cavity and pharynx. And the fibers for the salivary gland, submandibular, sublingual, they were passing down through the facial nerve and was emerging through the chorda tympani joins to lingual nerve to supply this submandibular, sublingual and the lingual salivary glands. So in cases of injury, or sometimes that might be due to regeneration, if there is the fibers coming from lacrimatory nucleus, they are preganglionic fibers to the lacrimal gland, and fibers coming from superior salivatory nucleus, they are preganglionic parasympathetic neurons for the salivary gland, submandibular and sublingual. So these two preganglionic fibers, they fuse within the geniculate ganglion, right, because of regeneration. And they regenerate because neural lemma is intact. The endoneurium, within the endoneurium where these axons are running, the axons, the two preganglionic fibers for the lacrimation and for the salivation, they fuse. So what happens is the person, while chewing, while eating, also sheds tears. That is called crocodile tear syndrome, means tearing while eating. And overflowing of tears is called epiphora. When you have uncontrolled tearing, that's called epiphora. So that's crocodile tear syndrome. You find the subject, the tears drop down from the eyes while chewing, while eating. That's crocodile tear syndrome. Then another point here is clinical point is Ramsay Hunt syndrome. This is asked, and it even might be asked with a figure, because nowadays MCQs in your PG entrance exams are being asked giving a figure. So can you focus now here in this figure, Ramsay Hunt syndrome? Let me tell you, Ramsay Hunt syndrome again has similar conditions which I have already taught to you. This Ramsay Hunt syndrome, remember, is related to geniculate ganglion and the virus which normally lodges there, which reaches to this geniculate ganglion, herpes zoster virus. So if you remember, while I was teaching the spinal nerves, I taught you that the afferent course that this virus follows from the outside, skin infection. The virus through these afferent nerve fibers will reach to the first order sensory neurons and their cytons lodge within the dorsal root ganglion of the spinal nerve. So in immunocompetent patients, the virus lodges there in the DRG or dorsal root ganglion. And if in an immunocompromised subject, this virus flares up and again it spreads around with the course of the spinal nerve, and it will form vesicles and blisters and itching in that particular dermatome, and that's called shingles, right? So this is herpes zoster virus. Same thing I taught you when I was teaching trigeminal ganglion. Remember, trigeminal ganglion, Gasserian ganglion is the same as dorsal root ganglion. It also is a sensory ganglion. So the virus can be lodged there also. But remember, in case of virus being flared up from this trigeminal ganglion, the herpes zoster virus, which is lodging within this trigeminal ganglion, there will be blisters, these vesicles around the oral orifice. If you find, vesicles and itching and even painful vesicles around the oral cavity, around the upper lips, remember that is the area of maxillary nerve. So in and around the oral cavity, if you find vesicles, that is actually due to virus within the geniculate ganglion which is flared up, which have like colonized and immunocompromised subject, the virus flares up again. Now in cases of geniculate ganglion, geniculate ganglion is again the same as dorsal root ganglion, the sensory ganglion. All first order sensations like taste sensations, then general visceral afferent, special visceral afferent, as well as remember from important is not from these visceral sensations, rather somatic. Let me specify more clearly. It's general somatic afferent which brings this virus. General somatic afferent is sensations from the skin, and that is the auricular branch of vagus. Remember, auricular branch of facial nerve, which along with Arnold's nerve is auricular branch of vagus. So the two nerve communicate, auricular branch of vagus, auricular branch of facial nerve, and they innervate the skin around the external auditory meatus or the base of the pinna. So the sensations of touch, pain, pressure are brought in through this functional component, general somatic afferent. So in cases of herpes, this virus here which lodges in this geniculate ganglion is called herpes zoster, oticus, herpes, because of the ear, external ear, right? Oticus, herpes zoster oticus virus. So again, what will happen, because if it's damaged, it will damage the lodging there within this ganglion, geniculate ganglion. It will damage the neurons there, right? So damaging the neurons, remember I told you injury of facial nerve at different sites, all things will be paralyzed. If geniculate ganglion is paralyzed, lacrimation will be lost. So in Ramsay Hunt syndrome, what are the losses suffered are loss of lacrimation, loss of mucosal secretions around the mouth, loss of salivation from some mandibular, sublingual and lingual glands, then loss of taste sensation from the anterior to the tongue, and hyperacusis will be there, and ipsilateral paralysis of the motor muscles of the face, ipsilateral paralysis. All these things will be lost. Remember that I told you, when there will be injury of facial nerve at the geniculate ganglion or proximal to that in the internal acoustic meatus. In addition, remember what additional point you will find is, you will find there, you can see here, can you see here, you will find vesicles, and these are painful vesicles in the external auditory meatus or at the base of the pinna. This is a confirmatory, because here it can be any other lesion also, but if you find vesicles here, that is this is distinguishing point about the Ramsay Hunt syndrome. Vesicles in the pinna around the external auditory meatus. Got it now? That was about Ramsay Hunt syndrome. Now hold on, I think that would have been, this is okay. Now look here, we will now study about clinical testing of the facial nerve branches. Facial nerve branches, here we are talking about the 5 terminal branches on the face. So to check for temporal branch of facial nerve, it innervates frontalis and the upper portion of Orbicularis Oculi. So how you going to check is, ask the subject to see in focus in front, and at the same time ask him to see upside to the ceiling. So they will find transverse creases on the forehead, and he will be able to elevate the upper eyelids in support of through the support of frontalis. Right, so that is the check for temporal branch. Then to check for the dilators of the mouth, includes the zygomatic and buccal branches, even the marginal mandibular, depresses of the lower lip. So you ask the subject to expose his teeth, like when you brush your teeth. So to expose the teeth here, the muscles involved will be, risorius is one important muscle here, risorius, as well as elevators of the upper lip. You have zygomaticus major minor, levator labii superioris, levator labii superior alicnesi, levator anguli oris, as well as depressors, depressor anguli oris, depressor labii inferioris, right? So these are the muscles which will help to expose the teeth. Mainly it's risorius, right? There you can check for the buccal and zygomatic branches. Then to again another check for temporalis is, remember I told you to the this temporal branch will supply the upper portion of Orbicularis Oculi, while the zygomatic branch will innervate the lower portion of Orbicularis Oculi. So to check the temporal and zygomatic branches, you simply ask the subject to tightly close the palpebral fissure, to close the eyelids. Ask him to close the eyelids, and then you passively ask him this to close the eyes, and what you're doing is you have to elevate the eyelids manually, and the subject, if it's normal functioning, you will find that you are not able to open the eyelids. Why? Because remember, if a person is sleeping, I think you can easily put your finger on the upper eyelid and you can open the eyelid if a person is sleeping. But if a person is mimicking to sleep and then you see him do the same action, you will not be able to close the eye, you will not be able to elevate the upper eyelid. Why? Because, not telling me, let me tell you again that Orbicularis Oculi has three parts. Orbicularis, the three parts are palpebral portion, which covers the upper and lower eyelid, then the orbital portion of the Orbicularis Oculi, which is around the bony margin of the orbits, and the third one is the lacrimal portion of Orbicularis Oculi. So lacrimal portion का important point है, people get confused. Actually it is not for the drainage of the tears, it covers this lacrimal sac, it's related to the lacrimal sac. So instead of drainage, remember what is the action of lacrimal portion of Orbicularis Oculi? Its purpose is for the dilatation of the lacrimal sac. It's a part of lacrimatory apparatus and it causes for the filling of the lacrimal sac. ठीक? So palpebral portion of the Orbicularis Oculi dilates the lacrimal sac. One thing. Now about the palpebral portion of Orbicularis Oculi. Palpebral portion of Orbicularis Oculi actually smoothly, or you can say calmly, easily closes your eyelids, which can easily be opened up by any external sources. If you are like you're sleeping or you being unconscious, your eyelids can easily be closed. So just to approximate the palpebral fissure, you need the help of palpebral portion of Orbicularis Oculi. But to tightly clinch the eyelids, tightly, so as to prevent them from being opened, there you need an additional reinforcement force from the orbicularis portion of Orbicularis Oculi, which is the circular, is a constrictor muscle around the margins of the orbit. So this, because you are checking this muscle, you have asked the subject to close the eyelids and you are elevating. What this person is using is orbital portion of Orbicularis Oculi, and that makes you sure that temporal and zygomatic branches of facial nerve are intact. Now this is to check for the buccal branches of the facial nerve. Remember, buccal branch was splitting into upper and lower buccal divisions, buccal branches, and the two branches were running above and below the parotid duct. So these buccal branches will supply no doubt the buccinator, the risorius, of course that also has been some of the muscles being supplied the marginal mandibular as well. But here the purpose of is to check the buccinator, right? The same thing is, when you ask the subject to blow air, right? So ask him to push them out and blow air. You will, and with the same time, at the same time, you place your fingers on the either side of his cheeks and ask him to blow air. So if buccinator is intact, you'll find the contractibility and the tightness in the cheeks while there is positive pressure created in the oral cavity. The buccinator will be, strengthened. But if it's intact, but if if this is paralyzed, you will find that the cheeks will not be taut on that side. Then further, if you ask him to whistle at the same time, you will find contraction of the cheeks on the side which is normal, but it will be not be contracted on the paralyzed side because buccinator is paralyzed, so the cheeks will not be approximated to the teeth. There you have studied about the checking of clinical testing of facial nerve branches. And lastly, one another applied point of this knowledge about facial nerve and its course. Remember, let me tell you again, from you see here, this is the pinna, and behind to that will be the mastoid process. So this nerve, when it emerges out from the stylomastoid foramen, it's running behind this pinna anterior to the mastoid. Got this? And it winds here after giving its posterior branch posterior digastric stylohead. Then it winds around the angle of mandible below to the temporo-mandibular joint, and it enters the parotid gland through the posterior-medial surface of the gland, where within it divides into temporofacial and cervicofacial, and it further gives its 2 branches from upper division and 3 branches from lower division. You all know that. The purpose of telling you here is that this nerve has a very close approximated relation to temporomandibular joint. And remember, there was this foramen of ovale in the roof of the infratemporal fossa, from where mandibular nerve was emerging out, and it was giving this auriculotemporal nerve. Auriculotemporal nerve is a branch of mandibular nerve, and this nerve was carrying secretomotor fibers to the parotid gland, right? So, and it was embracing auriculotemporal nerve. You remember the diagram? It embraces which artery? The middle meningeal artery. It embraces the middle meningeal artery and further continues to supply the secretomotor fibers to the parotid gland. This nerve, auriculotemporal nerve and facial nerve, both of them are in very close approximation to TMJ. Facial nerve from outside and auriculotemporal nerve from the inner side of the TMJ. So while doing surgeries, a surgeon has to be very sure enough of taking precautions to preserve the 2 nerves while operating upon temporomandibular joint. Okay, so we are done here.